Hi, everybody, and welcome to Oral Bites, our podcast. We are overwhelmed that Simon O has come to join us this evening. Got to mention the weather because obviously it's Britain, Simon, so I hope you don't mind, but it's absolutely chucking it down. And I've got a tin roof above me, so you might have to hear me raise my voice. You might hear this little pitter-patter as the beautiful rain just bounces off the roof. But what we're going to do today is we're going to share lots of information about full mouth rehabilitation with dental implants. This podcast is for anybody in the dental field and patients alike, really. Simon, he's an expert in the full arch implant dentistry. He's involved in a few businesses, which I'm sure he'll talk to us about. Smart Arch Dental, the All Annex Masterclass, Smart Back Foundation, and there's a couple of other businesses that you're involved with as well, Simon. And it'd be lovely to hear all about that over here in the UK. So I'm going to sort of hand over to you and sort of understand your journey and how you kind of manage everything that you do. I think it's absolutely incredible. I struggle with the few clinics that I work in, and I've got the wonderful Kate that helps me out. I absolutely find it overwhelming and absolutely incredible. But probably one of my first questions was sort of, how did you get into dentistry, and sort of what was that sort of aha moment that made you think about dental implants?
Yeah, Carl, thanks for having me on. Same with you, Kate. This is great. And I love getting on these kind of things when it's across different countries, because there's different philosophies, different ways patients are having problems, and the realities are slightly different, even though we do the same thing. So I think it's always a very interesting conversation to have. But in terms of my desire to go into dentistry, so I had a lot of teeth problems when I was a kid. I had lots of baby tooth extractions, lots of cavities, and I just had a very compassionate dentist growing up. And that sort of, like, I wasn't scared of getting procedures done, and I had a lot of them. And naturally that led to a lot of orthodontic issues, early extractions. And so I ended up in braces for about 4 or 5 years or so, and just really good experiences. I think when it came down to it, medicine versus dentistry, I think my gut just told me to go into dentistry. It made sense from a logical perspective with like work-life balance and using my hands, which I really enjoyed doing as a kid. But, just having shadowed both sides of things, it just felt right. That was that. And then over time in dental school, I gravitated towards the surgical aspect. There was an emergency clinic from the oral surgeons, and I spent like all of my free time there. I think I extracted somewhere in the ballpark for like 300 to 500 teeth when I was an undergraduate student. So I just lived down there, and I stayed late. I took all the complex cases, and I just couldn't get enough of it. That's what led me towards oral surgery, oral maxillofacial surgery. So I ended up in Philadelphia afterwards in a 6-year, I think you guys call it Max Fax, which I understand it is different than oral surgery in the UK. Like, they're two different programs.
Yeah.
Yeah. So, which is interesting because, over here it's different, and it seems like it's more of like I don't know. It's just kind of interesting to hear about other countries doing things differently. But yeah, it was a 6-year program, dual degree with an MD. I ultimately left during medical school, which is like the middle segment of the program, for a number of reasons. I think, for one, my back was really giving me problems. I had an injury as a kid when I was like 16 or so, and I have like herniated discs, and I was having issues with that. Financially, with another doctorate degree, it was another $200,000 to $300,000 in student loan debt. And I had gotten a lot of experience because it was a very heavy trauma program. We were doing a lot of facial fractures, and I felt good, So after that, I dove into sort of travel exodontia and implants. It sounds like you're doing the same thing, Carl, where you're traveling different clinics. I found a lot of freedom in that, even though it's a lot of traveling, because you get to work with other people. It's not the same old stuff every day, and the office drama gets left behind when you leave.
That's a bonus, right?
Yeah, absolutely. So, I did that for some time. I eventually partnered with that group, and that's when I started my leadership roles. And I guess over here, I don't know if you guys call it DSO over in the UK, but like organized group practices, like big group practices. I was the chief dental officer of a group of 8 offices, and we eventually grew it. When I left, it was at about 100 offices, multi-specialty. Which, it's a big number, but in the US, there's much larger there's like some that are like 1,200 offices, which is crazy to think about. But yeah, after that experience of being in the leadership roles, what was interesting to me was that while I was there, we were thinking about closing down a particular clinic, and I really enjoyed doing implants and the impact that it could make on patients, because it's a very immediate, instant gratification type of thing. And we were losing a lot of money at this particular office, and we were thinking about shutting it down. And I noticed that it was in a particular demographic. It was blue collar, lots of dentures, and unfluoridated community. And so I just said, hey, why don't we just market implants for like 3 months and see how it goes? And it exploded. So we were just doing tons and tons of full arches. And that was the genesis of Smart Arches, which is my practice group here in the US. And so I just dove in, and we sidestepped, we branched it off of the original company. And that's how it started. So we just do a lot of full arches. It's full scope though. Like in the US, it's interesting because there's a couple of organizations that only offer full arch. But I saw a lot of issues with that sort of model because when you're a hammer, all you see is nails. And I didn't want to be like that, because there was a lot of younger patients going through there and getting all their teeth removed. And like when I think veneers or something may have been appropriate. And so I wanted to be able to create something that would service anybody who just didn't know what they needed and just wanted a confidence booster because their teeth don't look good. So what we do is full scope. I call it full scope prosthodontics with backbone and surgery. So we do a lot of full arches, but ultimately, if like an FP1 type of rehab is appropriate, we do that. If crown and bridge along with some single implants is appropriate, we do that too. So, I just wanted to make sure we were doing the right thing ultimately. But that's my story in terms of the practice level of full arch and implants.
That's excellent. We have a couple of groups over here that do something slightly similar to what you just mentioned there. They sort of do focus mainly on the full arch work, and the way that they sort of do the other work is they collaborate with other clinics. And then if the patient isn't suitable for the full arch work, they kind of sort of refer the patient back into the collaborators, if you like, which is a very, very clever way of doing it, because they pick up referrals from their collaborators. Though it's a synergistic way of doing it. I don't think that they sort of aim at the same sort of patient base that you mentioned there. They do sort of sell themselves as purely full arch work. And we can probably talk about their practice, not necessarily their practice. I shouldn't say that. That's a bit unfair, but how they restore their patients with their materials immediately, might be different from what you and I do.
Yeah, sure.
Because I think that's important. But that sounds fantastic.
It really does.
And what you mentioned there about the differences over here in the pathways, we've got the NHS, which in some ways is really good, but it's struggling at the moment. So we've got, sorry, I don't know where the microphone is pointing.
Okay.
But in terms of the NHS, this is sort of like a government funded program. And so when it comes into dentistry, we've got that pathway that can take us through to oral surgery and max fax, but we've also got the private pathway as well. So there are sort of 2 pathways. And then in terms of the clinics, they're corporates. So we've got some large corporates, of which we do a little bit of work for as well.
We do indeed. Simon, what I'm going to say, which I think is absolutely lovely, when you started off a few moments ago and you said that one of the reasons you've become a dentist or you've gone into dentistry is quite the opposite to what some people say. You had a lovely experience as a child and you've reflected on it, even though by the sounds you have a lot of treatment done. That often can work the other way around, and it can make people, as you know, petrified. When they walk in, it doesn't matter if they're 30, 40 or 50, almost straight away, if they're nervous, they'll say, I had a terrible experience as a child.
Yeah.
So do you know what? It's absolutely lovely to hear the other side, actually.
Yeah, no, I'm very lucky because we hear that all the time in our offices, right? Like I didn't go to the dentist because I had a horrible experience as a kid and that's why they look the way they do.
Yep.
But I'm very fortunate because I had the opposite experience, you know. The dentists I was under the care of were just amazing human beings. So that really inspired me.
What a difference it makes, though, because look at where you are now, if you know what I mean.
Sure.
Yeah.
Yeah, you never know what kind of impact you'll have on people just by being kind, you know. It goes a long way.
I think it speaks volumes, really. That kind of just giving something back, I think. I was going to ask you about your influences. So I was fortunate enough to go to Ohio, and I met a guy called Larry Peterson, who I don't know whether you remember or have heard of, but he's unfortunately passed away probably back in 2000-ish. But he was a big oral surgeon, and he was doing implants, AMZ implants in those days, Simon. I don't know whether they're still around in the States, but I was doing some research with him on that. It was fantastic. And the way the university set up over there, Kate, is very different to over here. It's a huge, huge universities, massive programs and massive clinics compared to ours, and make ours look little tiny things.
Sure.
But he was a really big influence on me before I got into implants. And I've had lots of mentors, but is there anybody that you can think of that's kind of influenced you, and any mentors in your early days?
In the early days, so I was so focused on learning. I didn't have much money back then, so I didn't really take up any direct mentorship, but I just read a lot of books and articles. The person that inspired me the most was Ole Jensen. I don't know if you're familiar, but he was a huge impact on the full arch community with his papers years ago. And I've always known the name. I love the concepts and the creativity of using particular pieces of bone and angling implants in order to make things work. And that inspired me a lot. And over the years, I finally got an opportunity to meet him, and that was through his implant company, Ditron Dental USA, which is a subsidiary of an Israeli company. But that's how our paths crossed. And so that was probably like 4 or 5 years ago. Maybe at this point, I don't know exactly when, but I eventually joined the board, and he and I are we communicate quite a bit and bounce ideas off of each other, and it's been kind of a dream come true in that sense, because he was the biggest influence for me on the full arch side, and then I got to meet him and work with him, which is like pretty surreal, you know.
I bet.
Can
you remember the first time you placed an implant?
It wasn't in residency. We were doing so many plates and screws that and our dentoalveolar was pretty weak. So I think it was after that in 2014 or so. I remember where I was. The weather, you know, like when certain time periods in your life, you remember everything about like the scene and everything like that. This was in a town in Upper Darby, Pennsylvania. It was a tooth number 3, and I don't remember the dimensions. I think it was like a 5x8 or something like that, but I do remember.
And I bet it really doesn't seem that long ago in some respects.
Yeah, you know, time goes quick, especially in your adult life, you know. It does go
100%.
quick.
100%. I mean, the skill set that you guys have is phenomenal. And I mean, I've seen firsthand the difference it does make to patients. And I mean, it does sound like a cliche when you say that you change people's lives, but you do. And it can be a single implant, it can be a full arch, but you'll never ever forget those faces, do you? The patients, they light up. They really do. Really, really do. Never get sick and tired of seeing that, do you?
Yeah, no, for sure.
The rewarding part of the job.
Absolutely.
So do you have, I appreciate the teams that you work with. You have large teams. Have you been working with them for a long time?
So, you know, in dentistry in particular, I have a handful of different organizations that have started. Yeah, I mean, they range from big to small. The Smart Arches side, I want to say we're at about it's not that big, but it's probably like 50, maybe 100 employees or so. I have to count them. But that's probably my biggest one right now. But yeah, that's a bigger thing. And, that takes a lot of coordination and, delegation, things of that nature. And then I've got Orca, which is my, CE/humanitarian project in Guatemala, that there's 6 of us partners there. And then Masterclass, which is even smaller, which is about 4 of us. And, the Smile Back Foundation is my sister and I.
Really?
Yeah, so it ranges from big to small, but I think what I've realized over the years is that the people you work with matter so much. It's not a matter of skill set. I mean, skill set of course matters, but what matters more than that is mindset. I've come to find, because I mean, I don't have time to really focus on each one in particular. I have to have trust in who I'm working with to take care of certain things, but not just take care of things, but represent the organization the way that they're envisioned to. And that's a big deal. What's said without you there is really important, and making sure that they're aligned with the mission of the organization. So I'm very fortunate. I've met some really good people through the years, and I have a pretty strict rule that, and I guess it's like who you surround yourself with has a big influence in that. I really respect high levels of skill with high levels of humility. Those tend to be the best partners. Yeah, I'm very fortunate because I've come across a lot of really good people over the years.
Well, you reap what you sow, don't you? So it's, I think having, like you've said, I mean, reputation and people representing you, you've got to be able to trust them. You have got to be, because you can't be everywhere all at once. That would be amazing, wouldn't it?
Talking about trust, that was going to lead on to my next question, Simon. If we're talking to patients, what can we talk about in terms of what should we make them aware about if they want to find somebody they can trust? Sort of those things, because there are going to be some patients that are listening to this.
Sure.
What advice would you probably give them in terms of when they're looking at going down this road?
That's a really difficult question to answer simplistically.
Yeah.
Because the issue is that I don't think that you're going to find too many dentists that tell you that they're not good at something, or that like the outcome is going to be risky. So there's not that many people that I think would divulge that kind of information. So, it's really difficult to give advice on that and to have them really have like something meaningful to take with them on their consultation journey. I think, what I've been sort of advocating for is taking a look at, at least here in the States, there's like peer-reviewed awards that like other dentists vote on. And I've just said like, hey, take a look at that, because I'll get that question on social media from like people in Hawaii, California, like far away from where I am. So like I'm trying to guide them the best I can. And I don't know everybody in the industry, it's hard to say exactly who they're saying and how competent they are, and not to mention like, in dentistry, like most people actually do believe that they are the best, like, and so like, it's a really hard thing to sort of for patients, the consumers, to like wade through all that sort of, I don't know if you can call it like a smokescreen or something, to get to like what the truth is. But I would say like just ask as many questions as you can. Like how often do you do this procedure? How many have you done? What's your success rate? Where did you learn this? I don't know. I know it's such a hard thing for consumers to figure out. Even for me, like I had spine surgery about 2 years ago. It's like I was fortunate enough because my wife is a physician. Like I could ask her like, hey, who's the best neurosurgeon in this area? And she pointed me in the right direction. But like, say I didn't have that sort of like insider information. I would have no idea, because I'm sure like everybody I go to, they'll be like, I'm the best out there. You know what I mean? Like, and I've done this many, and like, they're really like into themselves. I don't know. It's such a difficult thing. And who's the judge? You know what I mean? Like who's judging everybody? I don't know.
I think one of the things I thought was very good that you said is that not everybody gets the full arch. And I think that's important. It's kind of making sure you've got that mindset where every patient you see, just because that's what they think they need, that's not necessarily what they actually get. It was clear from the outset when you said that, and I think that's really good.
Yeah.
Very
Yeah, for
ethical.
sure. I think at least here in the States, a lot of people are influenced by social media and they see certain people getting a procedure and the instant gratification, their life has changed and their teeth are nice, white and straight and they can chew with. And it sounds amazing. But like, what does that look like in 5 or 10 years or 20 years? We have no clue. And like, neither do they. So, I think a lot of people come in just wanting that because they're in pain, like in their life and psychologically, maybe. And they just want a quick fix, but that's not always the right thing.
You're right. Absolutely right. Sorry, Kate.
No, I was going to say it's not always easy to tell a patient that because it's not what they want to hear, but it is good advice.
Yeah. And these all on X cases, they don't always succeed. And I'm aware that you do revision on some of these cases. You take that to a level where I'm not at that sort of skill level. And it'd be lovely to hear about how you do that with a case that someone's had where they've had maybe 4 implants placed and things are starting to fall apart. Where do the patients then go from there? I mean, how do you fix that? And it'd be lovely to hear your views on that.
Yeah, revisions to me they are, I think, more about decision making than they are execution because, they require, like, at least for me, I do a pretty comprehensive workup because, like, first I want to know why did this fail, assuming that the implants were done well. I want to sort of get a sense of, like, is there a medical issue going on, a hygiene issue, or what was the type of implant, the grade of titanium? And then from there, I guess evaluating what they have and is it anything sort of like acceptable to keep, even though it's not perfect? Because what's worse than a failing implant is taking an implant out that may last a good amount of time, creating a huge hole in the bone. I think that's probably worse of a decision. It's a complexity that I appreciate because after doing enough of these, I call them virgin cases when they don't have implants yet. After having done enough of those, like the algorithm is pretty straightforward, but with revision work, it takes a lot of thinking about like, is this the right thing to do? And then from there, like, the best outcomes for me is when I can revise it without any zygomatic implants and utilizing the bone, whether it be like a palatal approach, transsinus, utilizing all the paranasal bone stock before I jump over to that. And one of the biggest utilities, and it may be, I don't know how controversial it is over in the UK, but there's a big debate over here in the States about pterygoid implants being utilized. Myself, along with like my circle of friends, we all believe in the pterygoid. And that to me is a big game changer because it allows for a lot more flexibility in the premaxilla. You don't have to jump to zygomatics nearly as often when you use pterygoid. Yeah, for me, the best success is when I can pull it off without any zygos. But ultimately, there's cases that you absolutely have to. So, but yeah, those are really fun cases because it's very thought provoking, and I love the challenge.
Yeah, I think. So over here now, we're seeing the pterygoids more and more becoming. I'm not going to say the norm because it's not the norm, but as a treatment modality. Whereas, before, like you say, it was much more down the zygomatic route, and now we're seeing the pterygoids coming in a lot more. There are more and more programs, although there's not many, but there's more and more programs that are teaching that, and they seem to be very well developed programs with very good structured teaching. Although there are one or two that maybe aren't so good. Again, I think while we talked about patients, you've got to be careful about who you choose as your training pathway. Yeah, I mean that's. In terms of sort of one of the modalities that we used to do with sinus sort of glyphs and a lot of grafting, you moved away from that?
In the full arch realm, largely, yeah. the only times I do a sinus lift are in two scenarios. One is if they just have nothing to work with and the zygos are thin. Like, even though this is a backup, sometimes it's not even there. So I will do a sinus lift like that. I just completed a case that I did a year ago where I had to 2 loads of bone grafts in both sides. But that was probably the only one like that in the last 6-7 years or so. So that's a good thing. The second scenario is when I have somebody very young that needs complex work. Even if, like, say they have severe atrophy and we're doing zygomatics, I'll do sinus lifts along with the zygomatics, which is the tricky thing to do. But I will do that just as a backup. I think when people say like zygos are the last stop and there's nothing that you can do after that, well, you could actually do sinus grafts while that all heals, and then if that fails, use the sinus lifts, so you can sort of jump back and forth between the two, is what I've come to find. But yeah, I mean, I think especially for the younger people that require this type of treatment, I will do a sinus grafting because, we need to be able to account for as many revisions as possible. I want to be able to have them maintain their teeth their whole life. And if they're in their 20s and they're edentulous and really resorbed, I want to be able to give them the opportunity. So 20 years from now, 20, like they may need 4 revisions in their lifetime, 5 revisions. So if that's the case and something happens, I want as many possible options to use as I can.
100%.
That's great.
In the surgery that you do, Simon, do you have a favorite dental gadget?
Favorite dental gadget or instrument? Not really. I wouldn't say so. I do have like my particular setup, but I wouldn't say I have like a favorite thing to use. Maybe the ronger. I use that quite a bit.
And with all the cases that you've done over the years, from single implants to the full arch work, is there a case that sticks in your mind?
Yeah, there's a patient that this is pretty crazy. So this woman, she's in her 40s. She had osteomyelitis of the maxilla before I met her, and had 27 or 28 operations on her maxilla, and she had nothing to show for it. She had absolutely no bone. So she got referred from the academic institution to a friend of mine who then referred it to me. We did quad zygoma, had complications twice. So I did 2 revisions on a quad zygoma, and she's about 4 years out and she's doing great. So she's in it. Yeah, she's been through a lot. There's also another similar patient that's from Mississippi who is one of the more difficult ones I've dealt with. And she had a similar amount. So like she started in the 90s with like calvarial grafts, like all the sinus grafting, all this like advanced stuff at an academic institution, and didn't have much to show for it. And so revised her twice. And finally got her done. She's doing well now. So, those are the ones I think, like, especially when an academic institution says they can't help them anymore. That's and I'm able to get those to work. Those 2, I don't think I'll forget who they are, what we did, that sort of
Well
thing.
done. And that's what I mean. It is life-changing. I know it's a cliche, but it really, really, really is.
Yeah. Yeah, those patients are really suffering. People think like dentures and like, oh, my grandma's got one, but like there's certain people that have like a level of resorption where they can't even wear one. If they're on the younger side, like they don't want to go out, they're not going to date, they're not going to enjoy a meal. Like that really sucks.
Yeah.
It really, really sucks.
Yeah, very much so. Do you find that managing patients' expectations can be as challenging as the surgery sometimes?
Absolutely. I have a theory. I mean, it's hit or miss because like sometimes patients come in and they look really, their teeth look pretty bad, and we get them temporary teeth and they look great and they are beyond happy. And that's what you sort of expect all the time. But sometimes like they get upset with you because like their tooth is not rotated, or like,
Yes.
and like, I'm just like, wait, what's going on here? I thought so, I think, but it's all about like your perspective and like understanding where you came from and where you've come. I think sometimes people forget that, and that they sort of hone in on what's wrong. There's a lot of mental sort of challenges that some people have. You forget that you have running water. You forget that you have no food scarcity in where you are, and that's why I really enjoy going to Central America to do work there, because like the patients have nothing. Like, they don't even have running water sometimes, and they are so grateful for everything. But in the at least here in the States, like and I don't blame them. It's a problem of society. I think that we just sort of have things and are ungrateful for them. Like it's a societal issue. It's not an individual one, I don't think. But I do see that, like they get really upset with you because like a tooth is not where they want it to be or rotated or something like that, and they get really mad at you. So I'm like,
As you say, sometimes it's that little reminder of where they've come from
yeah.
to where they are now.
Sometimes I alluded to it a little bit earlier on in terms of, I'm not sure what your treatment modality is, but one of the things that I don't do is I won't put a zirconia on at the beginning on the first phase, the provisional. I'm not using that. We've got some people in the UK that do, but I've got some reservations about that personally, and I don't know whether you feel the same.
I do, I think there's just like anything in life, there's pros and cons to everything. I think the pro of immediate or rapid zirconia is the rigidity and, the stability. The issue that I have with not the concept, but more so like the management of some of the providers or companies that are doing that, they'll do that, but then once the tissue recedes and they have food traps, they're relining it with composite, or at least that's like the go-to thing to do with a lot of these arches being done. And I just disagree with that from a holistic standpoint. There's a lot of different people saying that like the tissue doesn't change and like there's use a certain protocol, but like then they show the case. I'm like, I see the food trap. Like I see it right there. So like, as long as I think it's okay to do, as long as they treat it as a temporary and then they redo it later after the tissue changes, because we can't cheat biology, with prosthetics. Like, you just can't, like, at least none that I know of. But, time and time again, I see and hear of a composite going on top of the zirconium, which I just, and I don't have like the studies or data to look at it, but just from like what I understand about material science and prosthetics, I don't think it is appropriate.
No, I'm with you. I agree with you on that. I'm not keen on that. Let's say that. Let's put it
I
that way.
agree. Yeah, I'm with you.
I don't think we'll see the evidence that kind of says that's the best way to do it. If I'm really honest, we'll probably see the opposite.
Right.
One thing that sometimes catches me out, and I've been caught out recently, are undiagnosed bruxes. I find them; they can be I've even had one dislodge his bridge, and also very highly tuned into his occlusion. Do you find that can be a challenge?
Yeah, that's one of the the evolutions of dentistry that I think needs to be more mainstream, because it's not just like undiagnosed bruxism is definitely one thing, but the degree of bruxism too. It's not black and white, it's not either you're a bruxer or not. There's, I'm sure at some point we'll classify severe or moderate, so like, what I had a question early on. This was about 4 years ago, and this was actually the genesis of a great relationship I had with a prosthodontist who we did a startup company called Smart Mouth Technologies. But the conversation I wanted to have was, because I was very curious to understand, like, because zirconia has a measured millipascal strength measurement that we know of. How can we relate that to how much of a bruxer somebody is? And because I was an early adopter of a technology called the Enobite, it's a bite measuring tool. I adopted that about 4 or 5 years ago, and I have it in my clinic. And it basically tells us how hard they can bite at max clench. And so it's measured in newtons. And so I was on Facebook and I just put out there, I was like, hey, is there anybody smarter than me that can relate newtons to megapascals? Because I want to be able to choose my prosthetic material based on how hard they can actually bite, so I can pick the appropriate material for them. And nobody really gave me a meaningful answer until my now really good friend, Dr. Sven Bone. He's a really unique guy. If you don't know him, you should get to know him. Amazing human being, but on top of that, he's a prosthodontist who has degrees in mathematics and physics. So he's got like this really unique sort of seat in the industry where he can talk to engineers, but also the dental side. And he was like, "Oh, that's simple. You just do this." I was like, "Oh my God." So we got on the phone. I had never met the guy. I'd only talked with him on Facebook every once in a while. And we talked for like an hour, maybe even 2 hours that day about like, hey, like there's all these like shortcomings in dentistry. Like, how can we figure this out? Because it's either they're a Bruxer or not. I was like, oh, well, I use this thing. He's like, oh, that's cool. We should take those measurements and then select our material based on that bite force. But no, you're absolutely right. Like right now, nobody really knows of this product or uses it. I've been using it for many years, and it's a critical thing to do because, you're right. Bruxers will break your stuff. They will break your temps. They will break your finals. And ultimately, like a temp breakage, I'm sure puts the implants at risk. So on the surgical side, it's a really important thing to make sure it doesn't happen. And then the final, like they just spent all this money and effort. They're afraid of the dentist. They built the courage to go through this procedure. And then on the back end, they're having all these complications. Like that sucks. You know what I mean? So like the tools that we had before that technology was just black and white. It's like they're a Bruxer or not. It's like, how do you know? Oh, they have wear on their teeth. Oh, okay. Like really? Like that's all we could come up with in the 20th century. So that's my protocol today is like if they have wear facets or something like that, I have them bite on this thing, and like it's a very wide range. Like the for example, like people in full dentures with atrophy of their jaws and their muscles, and they can only bite like 200 newtons, but then like you get a really big guy with like, their FMA is like very flat and like boxy jaws. They can bite like 1200 newtons. And so we're talking like a factor of 6 difference of bite. And we really ought to treat them different in terms of how we engineer the materials, how we engineer the implant placements, how big they are, because, we haven't yet figured out, we know that there is traumatic occlusion and enough force will cause an implant to fail, but we haven't defined how much that is. And what is like the difference in implant length or diameter going to make a difference? And if so, by how much? We haven't figured a lot of those things out yet. So that's sort of like what Dr. Bone and I are working on right now with, it's called Smart Mouth Technologies, which is kind of like a play on words. It's like like at least here in the U.S., someone that you call a smart mouth is like a jackass or like
Yeah.
somebody, you know what I mean? So like we call it smart mouth for that, but also like smart. Like, we're using technologies, and so we're using a lot of different engineering tools, and we're getting into AI to be able to have predictive modeling on prosthetic breakages. We made a screw that's not. It's a direct to multi-unit screw that has the best clamping force, least fracture vulnerability, that sort of thing. So that's what we've been working on. But I think there's still a lot of room to grow. A lot of problems left that we haven't really fixed yet. But yeah, that's my long answer on the bruxism topic.
You sound a very, very busy man. A very busy man, Simon. What do you do in your spare time? If you have time out of dentistry, what would you go to be?
Yeah, probably a golf course.
Oh, okay.
Travel and golf, and and spending a lot of time with my kids. That's what I was doing all day today. I don't take work meetings on weekends. I'll do podcasts and stuff that's like fun, but like I don't want to be in work mode on the weekends. But yeah, the golf course and travel, and I'm very fortunate because I do get invited to different countries to speak and do courses, and so like that sort of fulfills that side of things.
You can marry those up nice together, really, travelling and golfing, can't you? With the different golf courses around, I'd imagine.
We've got some nice golf courses over here.
We have.
Yeah,
We have.
absolutely.
How old are your children?
8 and 6.
Okay. So are they thinking of a career in dentistry, or are we not going there yet?
No, I want them to do what they want. I'm not, my parents were immigrants and first gen and war survivors. They survived the Korean War, and so they really pushed myself and my sister to excel. But I want them to follow, their passions. Right now, it's kind of like the typical kid answers, which is like firefighter, artist, writer. So I'm like, that's fine. I'm not gonna say no, you have to do this, but it's
Absolutely.
fun.
Absolutely.
Yeah, they'll find that path. Yeah.
Yeah,
We're just there to guide them. Yeah,
absolutely.
I
Steer them.
like that. Yeah. Yeah. My sons aren't going to do dentistry. Well, he's already in his career,
Okay.
but my youngest, no, he's physiotherapist is what I think he's going to go down.
Good man.
But he wants multiple businesses.
Yeah.
There's nothing wrong with that.
There's
Nothing
nothing
wrong
wrong with that.
with that.
Nothing wrong with that at
No,
all.
it's great. Yeah.
My oldest, he works for a company, Jaguar Land Rover. You probably know Range
Yeah.
Rovers. You got them, yeah. So he works for them. And they've
Very
had
cool.
an interesting time of it. Yeah. It's great. So when are you next in the UK?
Yeah.
In the UK, I don't think I have anything on in 2026 in the UK.
We'll have to get you over. We'll have to get you over.
Change that. Bring your umbrella.
Sure.
No.
Yeah, right. No,
We're being heckled.
yeah, I've got a bunch of buddies over there, so I'd love to come over and hang out and just experience London. I haven't really been out and experienced the culture too much. It's been more business or just passing through,
Oh, okay. Oh, well, then you must. You absolutely must. Thank you so much for your time, Simon. Honestly, I'm sure I speak on behalf of Carl and myself. We were very excited to have you on here, and we appreciate again what you've just said. I appreciate you said you enjoy doing podcasts, but still, it is over the weekend, and you've been amazing. You're very interesting. I could talk to you all night.
Yeah, absolutely.
It's been a privilege. Thank you very much, Simon. I really appreciate your time.
Really has. And
really nice conversation.
We wish you all the very, very best. It all sounds very exciting.
Thank you very much. And you as well.
Well, thank you very much. Good evening, gentlemen.